Thanks, Dr. Sharma, Dr. Narula, Dr. Kinney. Thanks for having me. It's a pleasure to be able to break grounds and come here. I think I'm the most fortunate person here because I'm starting at ground zero as an endocrinologist. I have the most to learn, and indeed, I've been doing that. What I'm going to do is speak about, I advance this with this. With this. Got it. What I'm going to do is speak about diabetes, patients with diabetes, but I want to provide some context. The title of the presentation is Emergent Paradigms, so I'm going to take the prerogative to pick how I envision the future in the way in which we manage our patients with diabetes. We'll define the problem. We'll go through what the extent guidelines and algorithms are, the knowledge base, look at what kind of evidence is out there, and then we'll put together a new model, which I dare say is going to be challenging for us to implement, but also is going to be necessary. So there is a very high prevalence of type 2 diabetes, not only domestically, but as you go around the world. But this is a cosmopolitan city, and it's a country of multiple ethnicities and cultures. So really, just to say that there is a problem globally is not academic. It's something we deal with in our practices on a daily basis as we encounter patients from different ethnicities and genomics, epigenomics, and all of those complexities. We're learning more about the pathophysiology of type 2 diabetes, but indeed there are obstacles to implement what we consider to be the best practices or evidence-based medicine. There are knowledge gaps, there are emerging roles for health promotion. There's certainly inadequate research, education, and training in lifestyle medicine, and that's where we're going to end up. We're going to look at lifestyle medicine in the context of this growing problem. The U.S. is ranked third. Right now, it'll be third in a few decades for the prevalence rates of type 2 diabetes. It's a complex disease, as obesity is a complex disease, and in fact, as all chronic diseases are complex. Now, complexity 10 years ago, 15 years ago, et cetera, was something that we as physicians emotionally feared. We tried to parse these things out. We had a reductionist model. Everything was linear. We had component research. We focused on one drug, one pathogenic mechanism, and that was the evidence, and that's the way we applied it, and that's the reason why we ended up with a lot of errors and imperfect solutions and had to pivot as our candidates for the presidential election are doing all the time. If we look at the ACA, following up on that thought, if we look at the Affordable Care Act, we see that prevention is somewhat aspirational. It's baked into a lot of the finances. You heard about shared risk and about some of the other things that we're seeing in the new healthcare environment. But indeed, it is this adoption of preventive behaviors. But let me introduce to you two new facets to this. We've heard of primary prevention. You're at risk preventing the disease. Secondary prevention, you have the disease at an early stage, asymptomatic. There's a numerical surrogate. You want to prevent it from getting worse. And then tertiary, which is what our monuments to healthcare are, big institutions like Mount Sinai and Columbia and Harvard and all over the place. And this is oriented toward disease management, very inefficient, lots of costs. You've seen the curves. Well, consider, if you will, primordial prevention to one extreme, and on the other extreme, quaternary, there's an R missing, it's a typo, quaternary prevention. Primordial prevention is when you have a population, you presume not at risk, and you want to prevent those risk factors from emerging. And that could be anti-obesity legislation, supersizing, a lot of the stuff Mayor Bloomberg was doing, but on a vast scale, a lifestyle medicine scale, but to manage that population. Quaternary prevention is to prevent the over-medicalization of the patient, to prevent iatrogenesis. So consider lifestyle medicine as a tool to intervene. We're supposed to be doing it anyway. and it is not mutually exclusive with pharmacotherapy or with surgery. It's in tandem with the drugs or in tandem with the procedures that we do. We just lack the training and the know-how as far as how to implement lifestyle medicine. But by reducing these expensive interventions, you can see downstream what the advantages would be. American Association of Clinical Endocrinology, American College of Endocrinology put together a consensus algorithm and clinical practice guidelines for diabetes, type 1 and type 2. We're going to focus on type 2 diabetes. In this most recent version of it in 2016, we have this lifestyle medicine algorithm we put in, or really it's a roadmap, and we've blown it up a little bit more for 2017. But essentially you have the 5 features of nutrition, physical activity, sleep hygiene, the behavioral component, and then smoking cessation. Now, if we look at where we are right now, state of the art, it is a complication-centric clinical practice guidelines. We're zooming out on the problem. We're recognizing that the old paradigm of diabetes management ought not to just focus on glycemic control, ought not to just focus on reducing A1C or the fasting blood sugar. We've learned our lesson from ACCORD and VADT that when we aggressively target these ambitious A1C numbers, we actually cause more harm, quaternary prevention, right? And really we want to look at the whole patient. We would look at all the other cardiometabolic risk factors that come into play. We want to identify that biologically relevant endpoint. So we have algorithms for the overweight, obese patient, and also in pre-diabetes. And you can see where lifestyle therapy figures in. It's just a green bar at the top. Hardly ever exploded, hardly ever granular in these algorithms that we read about. We're somewhat psychologically disinterested in it. We're more interested in the sexy part, about the drugs and how many drugs and when you start the drugs and the dosing of the drugs and the cost effectiveness of the drugs and the evidence base of the drugs, the interactions, etc. That's our mindset. But if you look at what we're actually doing on a population scale, this isn't really working. Glycemic control algorithm will start with metformin, but the issue is what's the best next drug to add? But we skirt over the issue of lifestyle therapy or intensive lifestyle intervention. Same thing for insulinization. Lots of numbers, lots of algorithms and subroutines on how to best insulinize a patient. Avoid hypoglycemia, of course, but where's the lifestyle? Of course, preventing and managing atherosclerotic cardiovascular disease. Of course, we have hypertension algorithms and the use up front of ARBs and ACE inhibitors. Of course, the primacy of getting control of the lipid status, whether you adhere to what we're going to hear from Dr. Lloyd-Jones later on, basing it on your risk stratification at first or basing it on treat to target with LDL. That's something that will be settled, but it's part of the comprehensive management of patients with diabetes, not just focusing in on the number. So if diabetes should be considered in this holistic approach, then maybe we should expand this to include metabolic syndrome or cardiometabolic risk or cardiometabolic syndrome, this jumble of all the different words and terms that we have. And in fact, this was a think tank that ACE participated in with ACC, and we came up with different subtypes and different severity levels for the facets, the angles, the different ways to look at metabolic syndrome. Ultimately, if you adhere with what Scott Grundy says, metabolic syndrome is a way in which we manage residual risk. After you address each of the component risks, you are still left with a patient at some residual risk for cardiovascular disease. You can see that there are some of the things here that we know about. There are many things that we don't know about. Now let's move on to the heart. We found from some more recent studies that in fact, microvascular disease affecting the heart, affecting the body, does act as a predictor for macrovascular events or major adverse cardiac events. That there is this connection. In fact, with imaging, we heard a beautiful discussion on imaging earlier. There will be new innovations of imaging, and yes, for patients with diabetes, we will be able to risk stratify patients using these emergent mechanisms and techniques for imaging. But there's a lack of correlation of A1C with coronary microvascular function. That means there's a lot of other things that are going on other than just pure glycemic control. If we look at the integrative physiologic picture here, yeah, we got a lot of drugs that target different aspects. And of course, you could sit there and find all the permutations of the ideal cocktail of drugs. But I would posit, I would offer to you that lifestyle medicine from a networking effect, the effect of the different molecules, the portfolio of molecules in the foods we eat, the foodome, a made-up word, right? Physical activity, sleep, and the abundant and plethora of effects. They're going to ding all of these different nodes in this complex array of interactions. If you look at the different medications we have for type 2 diabetes, yes, they're all presented in the context of that delta A1C. They could be as low as what the FDA requires, 0.4 to 0.6%, like for the DPP-4s, as high as 1% for metformin, higher for some of the GLP-1 or incretin-based therapies. We even have data and an array and a prioritization of a lot of these medicines, including at the bottom of the slide, medicines for weight loss, right? You have a patient coming in, high risk, the BMI is high, not waiting, but coming in with pharmacotherapy for weight loss, which is going to have a broad range of salutary effects on not only glycemic control, but lipid lowering and blood pressure control, etc. So if we look at the approach for diabetes management in the context of CVD prevention, we start to see now an entire evidence base where a lot of these clinical trials are showing that these diabetes medicines are offering various aspects of cardioprotection. And in fact, if you want to have a nuance-based approach, as Dr. Halperin alluded to, with the selection of the different NOACs, for instance, you look at the patient population being studied, the leader trial for GLP-1 receptor agonists, maybe that would be best for those with prior MI. Pioglitazone, as I'm going to show you in the next slide, for those where you want to prevent a stroke. And in fact, you can prevent a stroke, and you can actually prevent in those with prediabetes using pioglitazone by 52%. And those are dose escalations from 15 to 30 to 45 milligrams. If you look at metabolic surgery, the new term for bariatric surgery, and I was part of the Diabetes Surgery Summit in London, spectacular outcome data, short term, where we're using various RUYs and BPDs, 100% partial remissions or incomplete remissions with BPDs. And if you define these as cures arbitrarily by John Buse in his study, his editorial rather, in Diabetes Care going out to 5 years, you see cure of type 2 diabetes. The endocrinologists originally, when I participated in this many years ago, we were dead set against positioning surgery in our algorithms for type 2 diabetes. But unfortunately, in our diabetogenic environment here, particularly on Madison Avenue, just south of Mount Sinai, with all the pastry shops and the restaurants and et cetera, and all those temptations, this is almost an impossible task to reprogram behavior. So yeah, you got someone who's at very high risk with a BMI of 42 and an LDL of 190 and an A1C of 12.3, right? And they're hypertensive, and you've tried and you've tried and you've tried, and you're getting nowhere. Yeah, surgery comes into play, and in fact, I would argue it does become medically necessary. We had a patient on our service some years ago that for diabetes, had a BPD, and while going through the process of getting the BPD, had an MI. Still did the procedure, and she's doing well. If you look at quality of life, this is from Stampede, but if you look at quality of life, you see quality of life markers improve with surgery for type 2 diabetes and durable effects going out to 5 years. Some other innovations, even for type 2 diabetes with insulin, where the beta cell reserve is down and they're on insulin and they're on pumps, closed loop. Now, in the ICU, that's our dream, to have closed loop, so we don't have to have this disjointed, these cumbersome, tight glycemic control intensive insulin protocols. We actually published a paper several years ago from our cardiothoracic ICU showing that stress hyperglycemia, in fact, was good. It showed an intact hypothalamic adaptation. Those patients who did not manifest stress hyperglycemia after cardiothoracic surgery, they actually moved from a 0 to a 30% mortality group without the stress hyperglycemia. So there's a lot of emergent information out there. And this would be the future, the bionic pump, the bionic pancreas device for those with type 1, for type 2, those who have a little extra money and just want to wear it. Who knows where this is going to take us? So now let's move on to lifestyle medicine. This is what I would want for your take-home message, if nothing else. Every patient that you encounter, rather than framing the discussion and the conversation in terms of disease, in terms of managing disease, preventing disease, severity of disease, what about framing it in terms of improving your health? So even if you had advanced cancer, even if you've had multiple stents and MIs and you've had surgery, we still want to act and work with you to improve your health. And every aspect, every decision node that's done has a component of lifestyle medicine. It is not mutually exclusive with drugs or procedures, but the problem is we are ill-equipped right now in 2016 to bring this about. We're dealing with a complex system. There's a lot of information that needs to be learned. We're dealing with chronic diseases. We define lifestyle medicine as the non-pharmacologic, non-procedural management of chronic disease, overweight, obesity, hypertension, hypercholesterolemia, type 2 diabetes. We can even parse this out in terms of cardiovascular health. What is a patient who has good cardiovascular health, who's healthy? That would be a patient who never smoked or quit over a year ago, a patient with a BMI that's less than 25 or less than 23 if they're Southeast Asian or Asian Indian, a patient with a healthy diet score of more than 4 or 5 components. Those are the 7 components of the DASH diet. And if they have 4 or 5 or more on a regular basis, we talk about eating not in terms of good foods or bad foods, saturated fat is bad and trans fat is bad. We talk about it in terms of eating patterns. That's the scientifically, biologically relevant way to communicate it. And then there's a checklist for lifestyle medicine that also includes sleep hygiene. It includes community engagement. How often are you going to the neighborhood places or in being active in the schools or your houses of worship to talk about health or to promote health? If you look at healthy eating, this is from Dietary Guidelines of Americans, Department of Agriculture, Health and Human Services, Institute of Medicine, all pulled information together, and the President's Council to identify. And then this was survey, how much of Americans are actually adhering to healthy diets? Not many. Component research, the use of pulses. How many people know what pulses are? How many people, raise your hand, know what pulses are? And I don't mean this, feeling the heart rate, right? I mean what goes in your mouth, a few. So if I go to other areas of the world, if I'm in India and I ask, everybody's going to raise their hand. Pulses are legumes and beans and peas and nuts and seeds. And there's a strong evidence base for cardioprotection. The amount of protein in the diet has been studied, but a whole food approach, not using supplements to get to that healthy eating pattern. And here's some of the data, the meta-analyses with those components, looking at coffee being protective for type 2 diabetes, whole grains, fruits and vegetables, nuts. And this is what I did. We put together a book working with some brilliant people here at Mount Sinai. And we basically built a network from the literature of all the different component research studies, looking at the genes that are involved in important biochemical pathways and the nutrient targets that interact with those gene products when the genes are expressed. And then from that, building up a menu of foods that could be tailored to that particular patient. Not particularly high tech. If you look at imaging, these are 3 people, different body compositions, all with the same BMIs. So recognizing the risk, for instance, with sarcopenic obesity, whether you're Asian Indian or whether you're just elderly, where the muscle mass contracts, and by virtue of that, even with a normal BMI, you have conferred an insulin-resistant state. So how do we put this together in a care model? What I would do is not use lifestyle medicine or metformin as your first step. The first step is to get to know your patient, to activate the patient. I had a referral yesterday from Dr. Fuster, a patient who had a BMI that was 50, a patient who was out of control. But of the 30 minutes that spent, 25 minutes were talking for me to get to know him, to activate him for change. In 2 weeks, I'll have the labs back. We'll see how he does. We can prepare for pharmacotherapy. But he's going to get started on his own. When a patient is activated, the job is much easier and the cost is less. You can see here a matrix of patient and physician power, how you can have a functional relationship and, of course, a dysfunctional relationship. The use of wearable technologies, pedometers, huge motivational tools. Tobacco cessation has to be part. Alcohol moderation has to be part of what you discuss. Sleep hygiene and synchronizing the drive for sleep with the circadian rhythms, managing that nap time, increasing the physical activity, increasing the way in which healthy eating is done, decreasing those late night carbohydrate snacks right before you go to bed, scheduling worry time to improve sleep quality. And then lastly, a transcultural approach. It's fine and dandy to have great evidence from our New York monuments to healthcare and research, but try to translate that to a Latino, African American, Southeast Asian, Asian Indian, Eastern European community somewhere else, and something's going to get lost. So we do have the ability now to a process to transculturalize. So for instance, in Asian Indians, from a pure cardiovascular disease, cardiometabolic risk, and type 2 diabetes, higher postprandial sugars, smaller beta cell mass, Barker hypothesis, lower BMIs, increased waist circumference, sarcopenic obesity, more inflammation. This is all from Shashank Joshi and V. Mohan in India that characterized this Asian Indian phenotype. We put a lot of this together in an issue of Annals of Global Health, formerly the Mount Sinai Journal of Medicine, from around the world to illustrate the differences and the different drivers of diabetes care. Community engagement varies around different locales. So let me sum up. Type 2 diabetes confers an enormous disease burden, directly and through complexity, indirectly. Current evidence-based algorithms are not optimized for cost. We're way behind the curve. We're pathetically behind the curve, particularly in light of a lot of the introductory comments by Dr. Rich earlier in the day. They need to be optimized for cost accessibility, address the disparities for healthcare accessibility and personalization. And the key message is that formally implementing structured lifestyle medicine can, in fact, address these type 2 diabetes optimization needs. Thank you.